it's early, but it's not as early as the 4 a.m. grand rounds. So it couldn't, yeah, it could have been worse. Okay, let me try to share my screen. By 2 years post-COVID, we should be able to do this easily. So my name is Emily Yosh. I'm a trauma surgeon, and I actually had commented on the chat about the Roboa I use. And if you guys want to reach out to me on the side, feel free to do that. We use a Roboa a lot here at VGH, and we put it ourselves in the trauma bay or in the operating room. So if you're ever interested in hearing more about that, I'm happy to talk about that. But I also do a lot of global surgery. This has been my passion forever. Basically, I went into surgery to actually do that type of work and to work in the lowest resource settings, and eventually founded the Global Surgery Lab, which I'll talk about today. So it's fully inclusive of all specialties and all disciplines in surgical care. Really hope you guys participate. I hope you're interested in what we're going to talk about. And it's a group that in which we welcome everyone. So if you have any interest in doing that type of work, feel free to reach out during or after the talk. And again, like I said, you can interrupt, ask questions, and I can answer the questions later or try to monitor the chat as we go. So just to set the stage a little bit, and you guys all know you're all surgery residents, so you know what we do is extremely important, but I think we also know that the pandemic has put that into light. We've realized that when you have strong surgical systems, you can actually fight big diseases, even pandemics. Initially, we didn't think we really had a role to play in the pandemic, but then we realized that having surgical capacity, having anesthesiologists, having respiratory therapists, having ventilators, operating rooms, having all this manpower actually really helps in surge situations. And in sub-Saharan Africa, for example, there's lots of places where they realized that the hospitals that did the best were the hospitals where they had functioning operating rooms and functioning surgical services, where they were able to absorb some of the waves of the pandemic. So I want to talk a little bit about, in general, what the gap is in terms of global surgery. And so what we want to achieve basically is timely access to safe, affordable, and high quality surgical care. And this has been spearheaded by the Lancet Commission on Global Surgery that was created in 2015. And if you want to read that landmark paper, Lancet Global Surgery 2030, that has really nicely outlined indicators and goals in terms of improving access to quality surgical care. And that's the first time we're really putting surgery on the map in terms of the bigger global health picture. So that's super exciting times for sure. And one thing that the Lancet Commission has put into light is that the #1 factor in terms of improving access to surgical care is augmenting surgical workforce. So all of you guys, plus, of course, anesthesiologists, plus nurses, all the support staff, everyone that contributes to the journey of a surgical patient through the healthcare system. And that's really important because that means that training people like us, training everybody, in the whole realm of surgical care really will be the key factor in improving this access. And that's something that we can actually positively act on. If you look at the big picture, the biggest gap in terms of access to surgical care is in sub-Saharan Africa, unfortunately. This is where there's the least surgeons, anesthesiologists, nurses, obstetricians. But that also applies to other places. So of course, other LMICs and LICs, but think about rural high-income countries. Think about our own country. And I'll talk a little bit about that later in this talk. Okay, if you look at this map, we've actually done a case study looking at South Sudan, which I'll talk about a little bit later. If you look at the surgical workforce density in this area of the world, thinking that our target is supposed to be 20 providers per 100,000 people, and that's 20 surgeons plus anesthesiologists plus obstetricians, all this workforce together should be 20 per 100,000. And in South Sudan, the latest number we have from about 10 years ago was 0.29. So the gap is huge, and it's nowhere close to anything that we can experience here in middle or high income countries. So this is really where most efforts are needed in places like that. If you look at rural Canada, this is a map that's also, I think, pretty old, it's 3 or 4 years old, but those red dots are communities and hospitals where you have physicians with enhanced surgical skills and or obstetric surgical skills who are working there. And so those physicians basically do a whole family medicine residency and then add 1 extra year to develop certain competencies in surgery or obstetrics. And then they go to work in rural sites and provide basic surgical care and really help save lives in places where there's no fully trained specialist surgeons. If you look at just the rural Canada, so anything that's outside of a catchment area of 100 kilometers of an urban site, the surgical workforce density there falls to 3.6 per 100,000 people. So we're in Canada, we're in a high income country, but we still fall way below the indicator that's 20 for 100,000 people. So there's tons of work to be done in our rural sites too. The big difference here is that our population is not mostly rural, our population is mostly urban, as opposed to sub-Saharan Africa, where most of the population is in those rural areas where there are no surgical providers. And so I'm just going to walk you quickly through this case study of South Sudan, which I briefly mentioned earlier. I gave this talk at Grand Rounds this morning, so I'm not going to dwell too much on this, but I just wanted to go through the process of trying to build a surgical training program in one of those very low-resourced places. And so I've been working with the MSF, Médecins Sans Frontières, for 7 years now. I've been to DRC and Central African Republic, and both times realized that it was frustrating for us to be delivering surgical services, but having no plan for sustainability. So in both places where I worked, there were no surgeons. There were no local surgeons. Basically, there was no one except us. And there was absolutely no plan for training anyone from the MSF side. And so I asked them if we could actually do some task sharing, a little bit like what we do here in Canada to train family doctors or general physicians to do surgical skills. And we would make it like very context relevant and really limited to essential surgical procedures and life saving skills to be able to actually create some capacity locally. So this took a million years, to be honest. So we started talking about this in 2015, which I didn't put there, but then I completely gave up and I thought they would never be interested in doing that. And eventually in 2019, they came back with a positive answer and wanted to pilot it in South Sudan in this hospital called a Whale State Hospital. We eventually signed an MOU, which is nice because now we have some formal partnership that's set up and we can actually grow this program in other sites. To sustain the activities of this curriculum, which is a ton of work, I'll talk about it a little bit later, I created the Global Surgery Lab, which is a very diverse and inclusive group and attracts a lot of students, residents, but also faculty, anesthesiologists, surgeons, obstetricians, and pharmacists. Like we really try to be as diverse in terms of the medical field and surgical field as possible. And basically, these people are really passionate about developing global surgery, about building capacity, and about doing this in a as non-colonialistic way as possible. So really trying to find solutions from the ground up, from grassroots efforts, and not just because we think that's a good solution. So this is members of our lab. We have about 45 members right now, and everybody's very active and doing very different things, which you'll hear about a little bit later. This is where our members are from. So of course, mostly from Canada and UBC since our lab is here, but we meet virtually. So everybody's invited to the meetings and there's really no discrimination where you're from or what you do as long as it's connected to surgical care. So as you can see, we have a member from Brazil and we have some members from Africa as well. So this lab was solely maintained by me for about 6 to 8 months. And eventually we were very lucky to obtain a big grant from UBC. And that's allowed us to actually build capacity within the lab itself. So we now have a full-time lab coordinator, Rosemary on the left here, who's phenomenal and actually helped me put together this talk. And we hired a project manager, her name is Mina, and will help us actually move our projects further and hopefully get to where we want to go, as opposed to having a few surgeons and anesthesiologists trying to spearhead initiatives, which, as you know, is extremely difficult from the corner of our desk with full-time jobs. So this is an exciting time, and that means that we have more capacity to do more projects. So in terms of South Sudan, I'll explain a little bit of what we've done because that's in line with what the Global Surgery Lab is all about. So if you look at this map here, this is a map of South Sudan, and all those red dots are all places where MSF has projects. They're not all surgical projects, but they're all like healthcare projects. And they've been in that country since 1986. The country was only born in 2011, but they've been in that region for more than 30 years now. And the project in Awil has been there for 2008. And in that project, MSF supports a pediatric hospital, and the main adult hospital is supported by the Ministry of Health, where they have 2 surgeons there, but they cannot staff the pediatric portion of the hospital. So MSF has been supporting that part for now 4 years. No, sorry, since 2008. So for now, 14 years. It's a very basic town. It's 100, 200, I think 200 and 250,000 people. So it's huge, but extremely not developed. There's no paved roads. And this is the operating room on the pediatric side. So 2 ORs, one bigger, one smaller. It's mostly like that in sub-Saharan African hospitals. You have a smaller room to do dressing changes, INDs, and small procedures, and a bigger room to do major operations. So because we had a mandate to actually build capacity locally and to train those general practitioners who are already working in that hospital and to build up their surgical skills, we wanted to make this training as practical as possible. So first we looked at all the case log from the MSF log books for the past 2 years and looked at what the main procedures and the most common procedures were. And then we divided those into modules so that it would be way easier to access and to navigate. So all this lives on the UBC platform. It's called Canvas. And we made 8 modules with all different, considerations from different fields. And we used a lot of resources, such as this textbook that's called Primary Surgery, which is extremely good for anybody who wants to work in low resource settings because it describes procedures within the local context and without using fancy tools like, for example, Roboa or things like that. It would just really explain how to provide surgical care with basic resources. And we also use a lot of MSF documents. We have local experts from Sub-Saharan Africa, from MSF, but also from UBC who've been deployed in a lot of low resource settings who helped us build those modules and make them as context relevant as possible. And of course, we engage our trainees into that process to give us feedback. So what the green boxes you'll see on the right-hand side throughout this talk are all the students who have or are actively participating in the different projects that we have through the lab. And so just to highlight their contributions, and basically they're the ones doing all the work and then we are reviewing it. And so the curriculum didactic content looks a little bit like this. It's pretty basic for now. We hope to make it much more interactive, visually appealing, and very interesting. But we kept it simple to start. We didn't have a lot of resources and time to do it. So this is an example of an orthopedic module on joint dislocation. So just trying to put as many visual things as possible so that it would be practical to read for trainees. And this can be accessed on a mobile phone as well as a platform that's accessible on your phone. And to complement those modules, we've actually made videos, which I don't know if they will play, I'll show you later. So again, like different techniques for traction, amputation. And again, all these were based mostly on the AO Foundation website, which is, again, as you probably know, is a really great resource for technical skills in orthopedic surgery. But also these modules have been reviewed by experts in the field. So to evaluate the modules in a didactic fashion, we created multiple choice quizzes that are at the end of each module. So the trainees have to actually meet the pass rate for those. And we try to make them as complex as possible. And then there's answer keys as well. So if they get the question wrong, then they have an explanation about why it's wrong and things like that. So there's a quiz for every module. Okay, this is not going to work, and maybe I'll show you later. If we have time, I'll show the videos at the end of the presentation. So we made specific videos for key surgical skills that the trainees said they wanted to see. For them, it's extremely difficult to browse on the internet. Like the Wi-Fi is not great, the bandwidth is very slow. And so having videos that they already have on their phone was really good for them and extremely practical in terms of like a just-in-time resource to be able to review procedure before they went to the operating room. So this is a fasciotomy video. We've made one on B-Lynch sutures. I don't know if I can open it. It's the next slide. A chest tube video and sorry, maybe this one will play. I'll try this one. I'll just speed it up a little bit. So as you can see in this video, we filmed those in the cadaver lab that we have at UBC, and we do about 4 cadaver labs a year. And in all those 4 cadaver labs, we film procedures, and then the students can edit the content and add the voiceover. This cadaver did not have a uterus; it was a male, so we were a little bit disappointed, but it's okay because we made our own uterus with a sock, as you can see. And the surgeon who's performing this procedure is a dually trained trauma and obstetric surgeons, who's actually worked for MSF for the past 15 years now, and is very experienced in those settings. And so he's the one doing the procedure. Our students are filming and then adding the voiceover, including specific illustrations that we make ourselves and a cue card to link to the video. So again, I'm happy to share those with you. And it's a ton of work to do, but it's been very useful for the trainees, and we've gotten really good feedback about it. In terms of didactic teaching, because we didn't want to have to travel abroad often to actually do some didactic teaching to the trainees, like we didn't think that this was cost effective or practical at all. We've organized virtual discussions through Zoom monthly and had talks on anesthesia, trauma, burns, pediatric surgery, orthopedics, gen surg, obstetrics, and even more than that. And it's been very engaging and very nice to stay in touch with the trainees and be able to successfully improve our program as we went. And this was basically our only contact with them as we were giving those talks. And those faculty are from UBC, so Dr. Tins Van Bornsen is an anesthesiologist who's worked for the Red Cross, has actually been deployed in Juba in South Sudan, and Dr. Hamid is a trauma surgeon who's worked a lot in South Africa and has extensive trauma experience. And we've learned a lot from the trainees to have improved the delivery of the content thanks to their feedback. In terms of evaluating technical skills, you guys all know what EPAs are by now. That did not exist in my time at all, and I regret it a little bit because I think it's a really nice way to have an actual practical and objective evaluation of your technical skills. So we did not have that. I guess we didn't even know if we were competent when we finished. We trusted our faculty, I guess. So we created EPAs to be able to evaluate our trainees in the field. And so I made those myself. Like we used some of the Royal College ones that were already done, but this was created in 2019 before a lot of the surgical residency programs had rolled to competence by design. So we kind of had to adapt our milestones. And plus, you have to know that these contexts are a little bit different, and the techniques will be a little bit different depending on what the resources are. So we couldn't basically just copy paste from the Royal College EPAs. So we made 59 EPAs for all, certain EPAs for each module, which had to be filled up by the MSF expatriate surgeon in the field. So that surgeon would actually walk the trainee through a procedure or observe them doing a procedure and then evaluate them and then send it back to us. our evaluation team, our student evaluation team, would compile them and then provide a report quarterly. And then we would have an evaluation committee, competence committee, evaluating and reviewing the trainees' competencies quarterly as well. So a lot of work just to actually gather all this data. This was mostly done by hand. So you can imagine we got a bunch of paperwork related to that. I'm sure there could be an app that could do this a million times better. We're not there yet. We're working on it. This is kind of the next step in terms of building the program and making it more practical and accessible. We wanted to make sure that we were not causing harm by creating a training program. So we've done a mid-program evaluation looking at patient outcomes first. We want to make sure the patients not suffer from having trainees operate on them. Of course, they were always supervised and they were only doing procedures independently if they were competent, but we wanted to make sure that this caused no harm. So there was no change in the surgical mortality or the surgical morbidity throughout the training. Both those numbers are not statistically significant. So this was reassuring to see, and we did not hear any counts of adverse events related to the training itself. Then we looked at how many EPAs that the 3 trainees had completed. They completed 327 EPAs over 2.5 years. Most of them showed full competency in the procedure. And the modules that were the most successful was module 1 is basically how to set up an operating room and doing safe surgery. Module 6 is a burns module, which was really well done and in which all trainees were competent. We looked at like how many EPAs were collected in terms of the training progress. As you can see, we have a huge gap because we started the training in July 2019. We didn't collect anything until January. This was because the surgeon who was present in the field was not properly briefed as to how to collect those EPAs. So we missed 6 months of data there. There's a gap during COVID in which there was no expat surgeon for 3 months. And the trainees had to rely on the Ministry of Health surgeon supporting them. And then there was a peak here in the data collection because a plastic surgeon from MSF actually went to teach burns and collected a lot of EPAs on the burn module. Overall, like I said, trainees became competent in everything burn related. So debridement, skin grafting, and this has been really nice to see. And this has been sustained in terms of their competencies in those procedures. They do much less obstetrics procedures. So their C-section, even if they've done more than 10 each, they're still not at the perfect score of 5 where they can fully independently perform a procedure without anybody being there. They can do it, but they need some supervision. And one of the biggest gaps that this project has is because it's a pediatric project, the adult side is staffed by the MOH surgeons. They don't have that many bigger operations such as laparotomies or inguinal hernia repairs, for example, bowel resections, stomas. And so the trainees were not as exposed as they should have been to this procedure, which means that they still required more exposure to actually build their competence. And that's one of the feedback that we got from the trainers, so the MSF surgeons who are deployed in the field in terms of the gaps in the trainings for the trainees. So again, it's just a matter of having more exposure to those procedures. We evaluated the training program through a qualitative study, which was done by our master's student, Mina Salehi. And this is a complex slide, you don't have to read it at all, but basically it was mostly positive feedback in terms of the trainees being feeling very connected with an academic institution and feeling like they were getting some education in a systematic fashion, and that they really received feedback regularly from the UBC staff. So they really, really liked that, and they felt empowered to actually train nurses, technicians, and other physicians and providers in the hospital with what they had learned. So there was a lot of transfer of knowledge, which was great. They felt locally accepted by the patients. So they felt like the patients recognized them as surgeons, which is very positive. And there were some drawbacks, of course, because nothing is perfect. But overall, in terms of, the acceptance of the program and the positive feedback from trainees, this was very positive. Just one thing about the feedback. So one of the things that they wanted us to do better is improving the accessibility of the platform, which we've done. So I told you it was on UBC Canvas. We've had to migrate it to another platform called Catalog, which now is fully open access, meaning you don't even need a campus-wide login, for example, to log in. You don't have to be UBC faculty or staff or have a guest account. It's way easier to log in. So that's going to help in terms of accessibility. They've also asked for things that made 100% sense, which are not in our control. So MSF has created this program as part-time training program. So I don't know if you can imagine being just a part-time surgical resident. That must be impossible. So that meant that they were only on a surgical ward and seeing surgical patients 1 or 2 weeks a month, and the rest of the time they had to work on the maternity or the pediatric ward. So that really took away from their exposure. So they asked for the training to be full-time. And they also asked that we sent them to other MSF sites to complement their skills. So, if they were missing things like laparotomies or complex obstetrics, that they were able to go to another MSF hospital to actually do higher volume of that specific procedure to be able to fill in the gaps in their training. So all this is, in the works, and we'll be discussing with MSF on how to better improve this training program moving forward. So I've already said that the biggest gap is in sub-Saharan Africa. So we're thinking about how to scale this training program, what to do next. But we also want to think about other LMICs, and we also want to think about our own backyard in rural Canada or other rural high-income countries. So for MSF, they've targeted Central African Republic as their second pilot site for the Essential Surgical Skills Training Program. There's very few surgeons there too. I think the ratio is probably like 2 over 100,000 people in terms of the surgical workforce density. I went to Bangui as an MSF surgeon a few years ago, and again, I was the only surgeon there. There was nobody there, and they were not even anybody to train, to be honest. There was maybe 2 other physicians, and they were extremely busy, and everywhere else in the hospital, there was absolutely no opportunity for training. So they said that they would work on improving that and maybe selecting a few medical doctors from other parts of the country to travel to Bangui and to be trained as medical doctors with surgical skills in that hospital, and then go back to more rural sites. So this is exciting, and we hope that we're able to improve the training enough so that it's even more useful for those physicians. We've actually also partnered with the Global Surgery Foundation, which works on building a big platform that's accessible to physicians all over the world to build their surgical skills. They're still in the infancy of that program, and we hope to be able to partner with them so we don't reinvent the wheel, and we can host or just have basically one home for all that surgical training platform. And in Canada, we've partnered with the Society of Rural Physicians of Canada, and in BC with the RCCBC, the Rural Coordination Center of BC, to see if we could actually collaborate on the obstetrics portion of the training program. So they've already started building a similar platform to ours to support the OSS group in Canada. And because we've created some material like the videos I've showed you on obstetrics skills, we're going to try to collate that together to actually provide this resource for the OSS physicians in rural Canada. It's very important for them to be able to maintain their skills. And sometimes they don't have high volumes in rural sites where they work. So having things like videos or even like mentorship and connections with other centers and obstetricians would be extremely valuable for them to be able to maintain their skills. So now I'll just shift gears a little bit. Please interrupt and ask questions if there's anything about the surgical program in South Sudan. But this was our main project. And from there, like we actually trickled down like a ton of different other things that are all related to mostly education. This is what we're mostly interested in. And these are projects that are almost all student-led. So you'll see again on the right-hand side, the students who are participating in those projects. So during the pandemic, we created an online course that's fully open access. It's still running. If you guys want to check it out, it's free. You can just Google it and go through the material. But we looked at what the role of surgery was in the pandemic and how it affected our workload and how to better protect ourselves. And working now on creating a last module for that course, looking in the post-recovery world, like how has COVID impacted surgery at large? Are there practices that we've changed? Are we going to switch to virtual care, for example, for a lot of our follow-ups and things like that? So this is something that's in the works, and we're really excited about that. There's more than 2,000 people who actually completed that course, which is really exciting, and that allowed some physicians from all over the world to connect with each other and learn from each other in terms of what types of obstacles they had to overcome through COVID. So this has been a really great experience. Since we talk a lot about virtual curriculums and virtual training, some of our students are passionate and really fascinated about innovative technologies. And so Kayung has looked into what the web-based platforms exist in terms of training, surgical training, and to see if there's anything that's adaptable to what we want to do in our own settings. And so she's looked at really cool models like the 3D cleft palate surgical training model. And as a side comment, there's a lot of material in plastic surgery, cleft lip, cleft palate, which is amazing. It's really well done. But then there's a big void in terms of everything else. You know, that there's not, I haven't seen 3D training models or anything else in trauma, for example, or other aspects of essential surgical care. So it would be nice to actually be able to scale up and adapt what's been done in plastic surgery to other areas of global surgery. And so Kayung has partnered with Courage, who's a medical student from Ghana, and who's told us a lot about the absence of surgical training in Ghana. Everything is located in the capital, and there's absolutely no support for training in district hospitals or rural sites in the country. And so he's connected with us to actually help support surgical training in Ghana. And what they want to do, I think, is looking at developing some virtual training in those sites. And so this is a study that hasn't started yet, but they're planning to do a full needs assessment to start, to see what would be most valuable for the trainees, and then implement a training program for surgical care, and then evaluating it. One of the things that's been identified as a very important marker or a very important topic or procedure for global surgery in that area is inguinal hernia repair. And so they're working right now with the 3D printing lab at BC Children's Hospital on creating a 3D model for inguinal hernia repair, which hopefully could also be printed locally in Ghana and be used for surgical training there. Our program in South Sudan and the ones that we're going to roll out hopefully in other MSF projects are competence by design. So we thought we would look at the competence by design format in other low resource settings in general. We wanted to know if there were lessons learned from other projects and curriculums, and if we could improve ours. And so Catherine, one of our students, had done a systematic review looking at competence-based medical education in low resource settings. And it's very interesting that first we didn't find that many studies. We looked at both rural high-income countries and LMICs. And so we only found 28 papers, and none of them talked about surgical training. So we couldn't really see any example of doing surgical training using competence by design. And lots of lessons came from those papers, which we thought we would apply to our training program too. So this is the map of where all the surgical training, all the CBME training programs were across the country, across the world. And most of them were medical training programs and or undergraduate medical training programs. Like I said, there was no surgical training program. And then a lot of proposed improvements from the trainees themselves was things like being able for them to visualize their progress. So having some kind of graph or map, roadmap to see where they were in terms of the training. Having more external examiners to evaluate their skills instead of having the instructors from their own training program. And then for the curriculums to be developed by a grassroots process, which makes 100% sense and which we really want to do in our own setting. In terms of like moving forward, we really care about not imposing our views in terms of deciding what's best for low resource settings for other parts of the world. Like we really know only what we know. And I think being an academic institution in Canada, we are biased, of course, and we do have some sort of a colonial lens that we really don't want to have if we can. So we try to partner with the people on the ground who really care about improving surgical care locally. And we want to do this in the most ethical fashion. So we published a systematic review a few years ago on developing pillars for sustainability and ethical partnerships, which you see here, the 6 pillars there. But again, this was just based on previously published articles, and it had potentially like a colonialistic lens, as a lot of partnerships, as you probably know, are first started by a high-income country institution like UBC, like Harvard, PGSAC, that has a very strong presence in global health and global surgery, and then partners with a local institution, but then the partnership is usually driven by the higher income institution and as well as the funding. So there's a lot of bias there. So we thought we would take those pillars and see if we could discuss them or have some buy-in or not buy-in by surgical providers from all over the world, from different WHO regions, and see if we could come up with a consensus on how to build an ethical and sustainable partnership. So Catherine is doing a Delphi consensus looking at this. And I think it's really cool that we got responses from all over the world. So you can see we have 50 participants. We're at round 3 now, looking at developing those pillars and those markers of sustainability. And those participants are located in all WHO regions. So we're not just asking Canadian global surgeons to actually give their opinion. They're coming from all over the world. And we're like integrating the comments as we go to try to build like not a perfect, but an optimal framework for us to be able to develop sustainable partnerships in an ethical fashion. Farhad, another of our students, is doing another study looking at a qualitative aspect. So he wants to interview surgical providers in Liberia. So we're targeting a specific country. And Dr. Jahar Fard, one of our lead of the Global Surgery Lab, is a pediatric surgeon who's worked there for a year. So she knows a lot of surgical providers in that country. But the goal of this study is to look at barriers to global surgery partnerships with high-income countries, looking from the perspective of those providers. And so we're employing a qualitative methodology so that we don't have any biases coming in. So we're really going to go without knowing what they're going to say and try to figure out how to best implement those types of partnerships without being colonialistic. And then locally here, we do have vulnerable populations, and I'm sure you're all aware of this. And we've never talked about this as much as this past year, and it's important that we do talk about it. We do need to talk about our Indigenous communities and fully include them in rebuilding healthcare and offering them better health outcomes. And this has to be done together. If you look at surgical outcomes in Indigenous populations, there's been a systematic review recently published in CMAJ, which made waves in a bad way, to be honest. It's really appalling to see how Indigenous patients all over the nation actually are more likely to die from surgery than non-Indigenous patients. So there's definitely some room for improvement and some call for action here. In BC, there's been a commission that's worked on Indigenous health in general, and it's called In Plain Sight. It's a report looking at health outcomes and also the racism and the cultural, how we basically stole Indigenous people's cultures throughout our history. And it's a very difficult report to read, and it has lots of patient stories that are heartbreaking, but also tells us that there's things that we can do, and there are leaders in the Indigenous communities that are willing to actually work with us on changing that. But it gives us kind of a background and some data on what to work with. And so this is a report from the First Nations Health Authority, and I'm not sure if that exists in your province, but here the healthcare system, the health ministry has actually created kind of a parallel healthcare leadership organization that's called the First Nations Health Authority, which is responsible for Indigenous health. And they're opening a first Indigenous health center in the northern region, close to Prince George. So that's really exciting. And they have certain priorities. Of course, they can't tackle everything, but the things that they are looking for the next 5 years are decreasing avoidable hospitalization, increasing the respectful treatment and respective traditions, decreasing the rate of infant mortality, rate of serious injuries, and increasing in general the life expectancy of their population. So all these things can be tackled with improving surgical care. If you think about it, a lot of, emergency visits are for surgical diseases. Infant mortality is 100% related to obstetrics care and good prenatal care, and as well as safe deliveries. So there's definitely something that can be done in that regard. And so we thought as a global surgery lab that we could work on this with First Nations and help them achieve those goals by improving access and quality of surgical care in rural areas. Of course, it's not going to take 24 hours, like it's going to be an extremely long journey. But we don't only want to work in sub-Saharan Africa, we also want to work locally as much as possible to provide support to our communities in our province and across Canada. And so some of our students have already started looking at some literature on postoperative outcomes in Indigenous patients. So this is a scoping review that's in the works. One of our pharmacists who works at Vancouver General Hospital is looking at developing a study which will be qualitative, looking at the perception of pain in Indigenous patients. So how they experience pain and how they experience the management of pain in the healthcare system. We do know that there's some racism in hospitals, but if we don't know how it expresses itself or what the consequences are, it's very difficult to address. And so we're hoping that through studies like that, we can start identifying potentially reversible causes of discrimination and improve the management of Indigenous patients throughout our province. We're also working with the enhanced surgical skills and obstetric surgical skills groups. As I mentioned previously, they work in lots of communities in rural BC. And so we're starting to map where they work and what they do, because we want to support them. We want to be part of the conversation, and we want to help them maintain those surgical skills to be able to better deliver surgical care to those communities. And a lot of those communities are Indigenous. So this will also hopefully help with improving the access to surgical care for Indigenous patients. So Rosemary, our coordinator, has created this map, which is amazing. And I thank her for that. And Maria is our student who's actually tried to collate to find all this data. She's been calling hospitals to figure out who works where. It's been very difficult. There's no centralized repository to find those physicians. So on this map, the purple flags are ESS physicians, so family physicians with enhanced surgical skills. The OSS ones are yellow, that's obstetric surgical skills, and the red ones are surgeons, like specialist surgeons. And as you can see, for example, here in Sechelt, there's a surgeon, but there's also an enhanced surgical skills specialist. So sometimes they work in tandem. If you look here, that's the interior region of BC. Revelstoke has only ESS physicians, meaning in that specific community, there are no surgical specialists. The closest one is in Golden, which is not that close, especially when the weather is really bad and there is no road access. So those physicians are very isolated, and we work closely with them to support their trauma care. They actually have a very developed telemedicine and telementoring system with that's integrated into the operating room. And so if they have a big trauma, then they connect directly with us at Vancouver General Hospital, and we can support them and walk them through the trauma. So we already have that collaboration going on, but we're hoping that we can actually scale this up to include more types of surgical diseases or surgical techniques through this telementoring process. Then if you look at Fernie, if you look at Cranbrook, so there's other communities where there's only ESS and OSS physicians. And again, these communities would benefit from more support and mentoring. And here is Northern BC. And as you can see, the more north we go, the less surgeons we'll have. But in some communities, they work closely together. So this is in the works. The map is not completed, but we're hoping that it's going to help create networks to build more efficient and sustainable surgical care. My next step personally, I'd like to take maybe a sabbatical next fall to actually explore those regions myself. This is the Freedom Hill. It's one of the coolest roads, I think, in BC. It goes down from the Chilcotin Plateau to Bella Coola. Bella Coola is an indigenous town with no surgeon, no operating room, but they can have pretty bad traumas and difficult cases there. So they have physicians who are completely isolated from the world. It's a very difficult place to get to. But I think it's important to like see what's going on in our rural sites and see how we can support them. I'm sure you guys have heard a lot about climate change, planetary health. This is kind of like the new sexy thing. And in surgery, we do have one of the pioneers of planetary health in Canada, Dr. Andrea McNeil here at VGH. She's a surgical oncologist and has looked at how operating rooms actually pollute the world and looked at how we could actually work to improve that and diminish our footprint in terms of surgical care in general. Because we do have a master's here at UBC, Master's in Global Surgical Care, where we try to, provide a bigger picture of what global surgery is and potentially propose solutions to improve access to surgical care. We want to make sure that we also do this in a planetary conscious way. So one of the things we want to work on in the next 3 years is looking at how to find a synergy between planetary health and global surgery, and to make sure that what we propose in our courses is in line with preventing climate change and reducing our carbon footprint. So this is super exciting. There's a few students on this project already, and we're really hoping that we can revamp those courses to make them more green. I'm almost done. I'm going to talk a little bit about how we do advocacy through the lab. We've launched a podcast called Off the Table, where we wanted to talk about things that were historically off the table, meaning grassroots efforts, problems that physicians, anesthesiologists, nurses, and surgical care experience in the lowest resource settings, and how to build solutions from there. We've recorded 7 episodes from different places in the world, including a GPESS from Revelstoke, BC, that I've mentioned before. We have a big team on the podcast, and it's really exciting. I really recommend that you guys check it out. I'll play some clips if that works from some of our guests over the past months.
I don't think the sound is coming through on those ones, actually.
So this is Dr. Shala and Ditya Kumar, who are both Indians and who voluntarily moved to a very rural community in India to develop a healthcare system, which is absolutely phenomenal. There was nothing there before they started, and they've dedicated their lives to actually building a hospital and providing surgical care and basic healthcare to the community. And they've empowered local community leaders to actually help develop and provide that care, which is pretty unique. So here he's talking about the fact that it's really important not to you want to become non-essential, basically, as somebody who's trying to build a surgical system or healthcare system in general. You want to empower the local community and give it back to them when it's sustainable, and not stay there forever. This is not the goal. Emmanuel Mikasa is an orthopedic surgeon from Zambia who's a huge champion of global surgery. You can see him on social media. He's very popular, and he's a very good speaker too. And Marcella is a surgical resident in orthopedics, who's done a lot of global health training. She's extremely well read, and she's a huge feminist and really defends the rights of women in surgery, but in healthcare in general, and was very vocal about getting the proper training to actually sustain surgical care in Sierra Leone. You can find us on social media, like all the the podcast apps I've mentioned before. And we also have a LinkedIn, which Rosemary has just created. You can just look at this, you know how to use those QR codes. I don't have to explain that, but yeah, just connect with us and see what we have on the go. There's a list of projects on the LinkedIn that links to our website as well. And just tell us about you and what you're interested in. The last thing I wanted to mention is that we're hosting the Bitumen Roundtable Global Surgery Conference this year at UBC. It's June 16th to 18th. And we chose to make it completely virtual because we wanted to make it fully accessible. We thought that having it in person would completely filter out anybody from low resource settings, low income countries that cannot travel here, especially during COVID, but also for financial reasons. And so, yes, it's maybe a little bit less engaging to have it on a platform, but at least it's fully inclusive. We chose a platform that's, it's a BC-based platform, it's Canadian, and it's pretty engaging. Like, and you can log into the platform and actually connect with different attendees and speakers ahead of time and create networks and have like little chat rooms. And we're gonna make most of those talks live discussions and not pre-recorded talks. So we really hope that everybody will participate. We have lots of great speakers, lots of controversial topics on delivering surgical care in indigenous communities, how to build global health programs without the colonialistic view. So please check it out. Like I think you have the link on there, or maybe on the next slide. Yeah. You can register whenever, and there's lots of really cool posters and putting presentations from trainees as well, which I think will be very exciting. So we look forward to hopefully seeing those of you who are interested on our platform June 16th to 19th. And in terms of moving forward, well, what we want to do is 3 things. We got that grant funding, and we want to sustain our activities towards, achieving those deliverables, which are mostly working on what we already have. So the curriculum that I've mentioned, the didactic portion, improving the figures, the videos, the EPAs, like all the stuff that goes with it to try to make it as relevant to both sub-Saharan African context, but also to the rural high-income country context. We want to make sure that what we do in global surgery has the best practices, is ethical, is anti-colonialistic. And we also want to share that with the rest of the world. Through the podcast, through social media, through our conference. We think it's extremely important that we start doing things differently and that we don't impose our views on physicians and providers in the lowest resource settings. So I think I'll stop now. Just the list of our Global Surgery Lab members, and I'm sure there's more. They're probably not all on there. And you can find us on this website as well. That's on the slide here.
Thank you so much. I've also been posting as you've gone along. I've sort of just been posting some of the links that you've mentioned. So I put in the Global Surgery website from UBC, the podcast link, and the link to the roundtable as well. I think in general, this was just interesting because, you talked about navigating these spaces and supporting these communities who have historically, not been allowed to thrive in the way in which they need to. So I think it's really great to hear about things, outside of Canada and right here with our Indigenous communities as well. And so I'm just, is there like 3 questions that you kind of ask yourself before you start working on something, or do you have like check-ins with the communities you're working with? I'm just wondering like how you really keep that communication open and provide support. I imagine that's a really tough space to navigate and to do well. So
no, that's a great question, and I think it's so easy to do it wrong too. That well, for the Indigenous part, it's something that I don't have an answer to, and the reason for that is we've tried to in BC, because there's all those different structures that already exist within the healthcare authority and Indigenous groups. We've actually talk to them first. Like we thought, we would not do anything that's not in line with the programs they already have in place. They already have provided like documents and with goals for the next 5 years, strategic plans. And so we don't want to not fit into that. So basically the ask was, how can we help you achieve those goals? And the obstacles I think we're facing locally is that they've been overwhelmed since, the Truth and Reconciliation and the In Plain Sight report in terms of like doing something, and for them to get organized, I think it's going to take a long time. So in terms of that piece, I don't have the right answer. I think my suggestion would be like wherever you work, there's always an Indigenous liaison person. There's always going to be an Indigenous like group, or just go through these people first before like even asking a research question, because I don't think we know what the question is. And so this is why we have put on ice like most of our Indigenous projects, because we want to have the right partners before we start anything. In terms of partnerships in low-income countries, so sub-Saharan Africa, for example, I've actually went through the MSF channel, and one of the really, I think, good thing, but it's also maybe a bad thing because it's an international NGO. But one of the good things about MSF is that they do have very strong roots on the ground, meaning that they only work with the local healthcare system. So they only work in countries where they have full support from the Ministry of Health. And so they have 100% buy-in. And then when they move into a project, it's usually an existing hospital, and then they work with the existing staff. They hire like local healthcare professionals. And if they can't, then that's when they fly in expats. So it was easy through them to actually have conversations with the trainees that we had in our South Sudan project, with the hospital director. So these conversations were really easy because they were all set up by MSF. And so we just basically followed their needs and just adjusted as we went. But I don't know, I don't have 3 questions, and I don't even know how to
That was
start.
specific. That's just how my brain
No, I
organizes
know,
things. So I
but
thought,
I
I thought
like
that
it.
could be a good way to frame it. Yeah.
It would have been nice, but I wish I had that. And to be honest, like that's why it took me like 4 years to get anything started, because it was just so complex and I didn't want to do the wrong thing. And just to engage the right people, you have to be very patient.
Yeah.
And so I think what I would advise against is those flying missions, where you think you're going to go and save the world and do a couple of operations and come back. This does not work. It causes harm, and maybe it makes you feel good, but it doesn't help locally. So just take the time to meet the people, ask the right questions, and know what they really need, and then just try to help, because they're not, they can do things on their own. What they're lacking sometimes is just things like, they can't create videos, for example. Well, it's easy for us to do that. So this is one thing we can help with. But they've actually taught us a ton about like managing certain of the pathologies that we know nothing about. So it's been a really nice back and forth. We have to be really careful about what we can offer and what we can give versus like, what they can bring to the table and what they need, and that we're not following our own agenda.
Yeah.
So
I think it also goes back to what the little blurb was saying from someone. You don't want to become an essential part, right? You want to help them to be able to sustain their own communities, which I think is really important.
totally.
I'm just wondering if anyone else has any other questions. And I'm also wondering if it's possible to share some of your slides, or if you'd like to share any of those video resources. We have like a good portion of our residents are actually either post-call or at home program events today. So some of them are going to be watching this either later today or in the upcoming weeks. But I will I'll post the link to the roundtable that's upcoming as well, your event.
Yeah, maybe I'll share the link to the videos that we made, because I do think they could be valuable for residents as well. Like we didn't make them specifically for South Sudan, of course. Like we try to target procedures that were high yield.
Yeah.
But I think we're all looking for more resources for surgical training in general. And if any of your residents want to participate, we're always looking for people who, want to do these things. And I see there's neurosurgery residents on the call too, and we don't have any of those procedures right now in the curriculum, and that doesn't mean that they're not important. That just means that we try to tackle, bleeding control and like infections first. But as we grow, we need to make sure that it's a curriculum that's fully inclusive of basically all essential surgical procedures in those settings, and that could include a burr hole.
Absolutely. Thank you so much for your time. I don't see any questions here, but if I receive any, is it okay to send them to you via email?
Yeah, 100% for sure. And then they can contact me directly, and then email me just to remind me what you need me to send you, and then
will do.
Thank you so much,
much.
Naomi.
Have a great day.
Bye, guys.